Thanks, Harry. So if anyone can hear me up the back. So quickly, I'm going to try in 15 minutes is to drill down into the mental and substance use disorders, which follows on from what Alan described as the overarching work on global burden of disease. So I won't repeat all the methodology that Alan went through, but you're aware that the disability adjusted life year made up of years of life lost through premature mortality and disability is the metric that I'm going to talk about, and that essentially combining premature mortality, years lived with disability gives us the DALY, but disaggregating that into conditions that prematurely kill people and conditions which disable but don't necessarily kill you is the way in which we understand a breakdown of the disability and mortality from health loss. Now, in GBD 1990, there were a number of mental and substance use disorders done, which was the first one done in that garage in Maine that you heard about from Alan. And all that Alan knew about mental health and Chris Murray knew about mental health then was that depression was important. There were 3 anxiety disorders in there: generalised anxiety disorder, PTSD and panic disorder, and they were modelled separately, as was bipolar disorder, schizophrenia, all illicit drug use together and alcohol use together. And so that that was the group that showed mental disorders, then called neuropsychiatric, and that's important because in that grouping, neurology and other conditions such as all of intellectual disability were grouped in this grouping called neuropsychiatric. That grouping doesn't exist in GBD 2010. Neurology, including dementia, is out in a separate group. So that's come out of the neuropsychiatric grouping, and that makes it one of the reasons it makes it difficult to compare the first GBD study with the latest one, which is why for this one we've gone back and recalculated the figures for 1990. So it showed that depression was the leading cause of disability, that mental neuropsychiatric disorders were, as a group, the leading cause of disability worldwide, and that 5 of the 10 causes of disability were from that grouping. For this GBD study, the mental and substance use disorders have been substantially increased in number. So depressive disorders is a grouping, and that is both major depressive disorder and dysthymia, including conditions like cyclothymia. All anxiety disorders were modelled as a group, not as individual anxiety disorders, and that epidemiologically was the way we had to do it, but it means that all anxiety disorders are now grouped, but we don't have individual estimates for individual anxiety disorders such as PTSD or GAD, but we do have a rating for anxiety disorders as a whole: schizophrenia, bipolar disorder, eating disorders for the first time, which was anorexia, nervosa and bulimia are in there. For the first time, we've got childhood mental disorders in there. They're very important. 40% of Africa, sub-Saharan Africa, are children. And to leave childhood mental disorders out greatly underestimated the impact of mental disorders in populations. So conduct disorder is in there, ADHD is in there, autism and Asperger's are in there. Also intellectual disability where it could not be attributed to another cause. And then there's a group of other mental disorders, which is the things we couldn't catch in that grouping. And there are things missing that you all as clinicians will know. The major one in this group would be personality disorders, which were not able to be estimated because defensible global prevalence estimates were impossible to generate. For illicit drugs, instead of doing them as a whole, we did 4 illicit drugs, then we did alcohol. So cannabis, cocaine, amphetamine type stimulants and opioids are in there, as is alcohol. We modelled dependence, not abuse. Somewhat controversial, but the data on abuse is almost impossible to get. But dependence was easier to get, but the way in which that's described has been technically challenging, and we won't go into that further. I won't go through this in any detail, but remember that essentially YLLs, attributable deaths by life expectancy, And for this model, as Alan didn't say, that males and females were treated equitably, so the poor life expectancy of males compared to females is not taken into account. It's expected that males should be able to live as long as females if they just behaved a bit better. For YLDs, prevalence multiplied by your disability weight. Okay, here we go with the results. So for total DALYs for the world, these are called tree maps. I don't know why they're called tree maps. Probably Alan and Chris one night after too much alcohol decided it looked like a tree. But they are called tree maps in the GBD lexicon. And you can see where cancer sits. You can see where mental disorders sit just next to cancer. The size of the area is equivalent to the size of the disability adjusted life years lost. Mental and substance use disorders, which is how they're called now after we've managed to get away from this North American term of mental and behavioural disorders. So they're mental and substance use disorders now. It's the 5th leading cause as a group. Cardiovascular disease, infectious diseases, neonatal conditions, cancer, and musculoskeletal are the first 5. And that 6th spot is important. I'll come back to it in the end as why it's important. We did our modelling for 85 of the 187 countries. That means we had data from only 85 countries that made it into the data set. We had to have, for any disorder, nationally representative epidemiological parameters that we could feed into DISMOD, which means that samples that looked at school children or looked at returned veterans or looked at female white-collar workers, all of that was discarded. Clinical samples, unless they were likely to be representative of the whole population or region, were also excluded. So treated cases of depression, anxiety, they were out. Some disorders we allowed in under that measure where we thought the country treated most of the conditions. The 2 disorders which were relevant for some countries in that case were anorexia nervosa and schizophrenia. But usually clinical samples are out, so it's hard to get samples. So only 85 of the 187 countries have primary epidemiological data, which means we had to model the estimates for over 100 countries from which there was no data. If we didn't do that, the burden of mental disorders would have been counted at 0 for those countries. So that the role of DISMOD became very important in this work. Another tree map showing the relative proportions from the various mental and substance use disorders. You can see depressive disorders, as Alan said, was number 1. Anxiety 2, illicit drug use 3, alcohol 4, bipolar 5. Some conditions such as schizophrenia ranked relatively low. That is because they're low prevalence of those disorders. However, in the disability weight methods, which Alan didn't get in time to go through, but disability weights were recreated for all disorders, all health sequelae as they're called. The highest disability weight given to any single health sequelae, more than quadriplegia, more than profound intellectual disability or profound dementia, was acute psychosis, acute schizophrenia. The highest disability weight, which means that societal disability rated that condition more disabling than any other health condition. So it has a very high disability weight, in fact the highest disability weight, but it actually has relatively low DALYs because the prevalence is low compared to anxiety, depression, substance abuse conditions. You can see the difference in the magnitude of the problem of mental and substance use disorders in developed and developing countries. So obviously here for developed countries, smaller contribution for developing countries because the relative burden of the conditions that cause high mortality, childhood infectious disease, nutritional deficiencies, etc., are more important. But as those conditions are more effectively treated or interventions to reduce them or prevent them are successful, individuals in those countries live longer and they live into the age group to get the conditions to which that age group is prevalent. Of the big non-communicable disease groupings, mental disorders, cancers, cardiovascular disease, and then neurological conditions, the first one you hit is mental and substance use disorders because they strike young adults and teenagers. Significant problems for those health systems which are geared largely to treat infectious disease, reproductive health, nutritional problems, having to come to terms with treating chronic disease. And that's a big challenge for those health systems. And as Alan said, for public policy, they need to understand the coming burden of non-communicable diseases. Sorry about this slide, but it is important for the reason I'll show you. This part here shows the global, you can see it, deaths per 100,000. So that's rates. And the rates of mental disorders largely hasn't changed. There is no epidemic of mental illness sweeping the world. If you go to the lay media, they won't have you believe that, but it's actually true. There might be stress and there might be psychological distress, but there's no evidence that globally there's a massive increase in depression or anxiety across the world, even in North America and Australia and Western Europe. What there is a growth in DALYs from those conditions, driven largely by population growth and ageing. That's what is causing the increase. Now, this isn't true for all disorders. It's not true for illicit drug abuse. Opioids and cocaine and alcohol are increasing in absolute prevalence in many parts of the world, developed and developing parts of the world. And the other one mentioned by Alan was eating disorders. It's unfortunate that young women in India and some parts of Asia are starting to look like young women in North America and Western Europe, and the prevalence of anorexia nervosa and bulimia is increasing in those countries. Okay, again, one of these terrible maps that you can't see when you put it on a slide, but basically it shows the age standard daily rates. Blue is low, red is high. The highest country in the world for mental disorders is Afghanistan. The rate of depression in Afghanistan goes from 5.6% to nearly 30%. The rate of PTSD goes up equivalently. Conflict at a country level acts like an infectious disease epidemic hitting a population. It drives up the prevalence of those disorders substantially. And it's true also, although the confidence bars don't tell us, but it's also true in Libya. It'll be true in Syria. It's true in Bosnia and Kosovo. It's true in some African countries. It's true in some parts of Asia. But in our modelling, it came out quite clear in Afghanistan. It was non-statistically significant for Lebanon and Iraq, but it was certainly headed in that direction if we had better data. So quickly, I'll finish off. I told you about the total DALYs, remember? The total YLDs, so this is just the disability proportion of the DALYs, shows mental disorders and substance use disorders are the leading causes of global disability. They're still larger than musculoskeletal, which is coming number 2. For individual disorders, low back pain is 1, major depression is 2, but as a group, mental disorders is the leading cause of, mental and substance use disorders, the leading cause of disability in the world. Musculoskeletal number 2. Prior to the first global burden of disease study, that would have been an impossible slide for anybody to imagine. Impossible. And I worked in global health and health systems prior to GBD, first GBD coming in, and we had nowhere near that data. But in fact, with all due respect to premature mortalities, health systems don't treat dead people. They treat people with disability. For health systems, health ministers want to know what are the people who are going to turn up for treatment and who we can't cure. And these make up a big lump of conditions, along with the sequelae of injuries and neurological conditions. YLLs, it's a skinny little bar here. And that's significant, and I'll finish off on that, why that's an issue for us. So coming close to the end, the global rankings, this is DALYs, as Alan showed you, so major depression is number 11. And remember, Alan said there was also a change in method where age weighting and discounting were dropped. Had age weighting and discounting not been in the first GBD, the estimates for neuropsychiatric disorders would have been 30% lower, 30% lower. So the impact of not having those technical issues in this needs to be understood. Nevertheless, they still turn out to be quite significant. YLLs, they're much more prominent. Number 2, as I've said, for major depression. Number 7 for anxiety. Illicit drugs is 12, alcohol is 15, and bipolar, schizophrenia and dysthymia make up are in the top 20. So they are significant in that group. They don't make the list of YLLs, which I'll talk about on the limitations at the end. So this is my last slide. So what I'd like to say here is that for the disorders that make up this grouping, they remain a major cause of this shift from communicable to non-communicable and from premature mortality to years lived with disability. Across the world globally, most countries have fairly stable rates. Conflict does drive the rates up. The only 4 countries who were significantly below the global estimates for the DALYs, once you looked at the confidence intervals, were China, Korea, Japan and Nigeria. They had statistically significant lower rates of neuropsychiatric than any other countries. There were some countries that were higher. The reasons that those countries were lower may well have been the method that we used. There were many NOS categories. For the clinicians here will know what I mean by those categories. There were, for example, in Nigeria, very high reports of medically unexplained physical symptoms presenting to primary care physicians that mental health professionals thought was palpitations, anxiety-related conditions, somatic manifestations of anxiety and depression. We would see it, but they were coded with unexplained medical conditions. And the difficulties using instruments such as the CITI to identify mental disorders in non-Western populations. So the need for primary data sources from those countries is absolutely critical. We only had data for 85 of the 187 countries, and we had to estimate and model the missing countries. So getting good epidemiology is good for understanding how accurate some of our estimates are. I'll mention in closing the issue of YLLs. So the small contribution that mental disorders made to the burden of disease was significantly challenged when we sent those papers for publication. All this data and much, much more will appear in 2 papers in The Lancet on the 29th of this month. So that paper is coming out in The Lancet, and one on illicit drug use is coming out in The Lancet as well. A lot of the criticism we've had when I presented the data and where the reviewers of those papers and other papers we've published have presented the data was that what about this high death rates in people with mental disorders? Like, we know that people with schizophrenia and chronic mental illness die much earlier than people without that. And yet none of that is captured in the GBD. Because to be captured in the GBD for YLLs, it has to be the cause of death. So rarely is depression the cause of death, or anxiety the cause of death, or even schizophrenia the cause of death. It's death by intentional self-harm, i.e. suicide. And suicide is coded under injuries. It's death by 80% of people in Australia with schizophrenia smoke. And they die of lung cancer, much more than the rest of the population. And yet, is it something about schizophrenia that causes them to smoke? Because the coding death is ischemic heart disease, lung cancer, or whatever the cause of death is. So somehow we haven't got a method yet that's sophisticated enough to pick up what it is about people with mental illness that causes them to die prematurely. My group has recalculated the GBD for mental and substance use disorders, adding the cause of death attributable to suicide, just suicide, into the data. So looking at psychological autopsy data and other data, about 60% of suicides in China, India and some other countries that we've grouped with that are due to mental disorders, because as you know there's a cohort shift in those countries to impulsive completed suicides that aren't thought to be due to mental illness, and about 80% of people in the rest of the world, their cause of death by suicide is attributable to being their mental illness. If you add that in, the proportion of the global burden of disease from mental and substance use disorders goes from 7.4% that Alan presented and I presented to 8.3% if you add that component to the YLL. And mental disorders as a group go from the 6th to the 3rd leading cause of disease burden. So that's just dealing with suicide alone. So we do have to deal with the issue as we get more regular updates of GBD, which we now have been advised will occur, to understand better the contribution that mental and substance use disorders make to the global burden of disease. Thank you very much.